एंडोस्कोपी करून दे आणि लीपी करून उद्या सकाळी आणि दाखवतात. ओके, थँक्यू.
Yes, ma'am, we are good to go.
Yeah.
Okay.
Yes, sir.
So once again, good evening, everyone. And on behalf of Emcure, I welcome everyone to this No Thrombosis National Workshop, which has been created by, I guess, the original and everything with Dr. Ichiporia, sir. And we're thankful to that. So quickly, I will introduce today's program director, moderators, and speakers. Let's go through it. So yes, we all know about him, Dr. N.R. Ichaporia. So he's a neurologist, director neurology in Sayadri Hospital, Yerwada. First neuro ICU and neuro intensive care of Pune he started. He has been a pioneer in thrombolysis treatment for stroke in India. He has like more than 300 public lectures and workshops on stroke. He's a member of Indian Stroke Association and organizing president of StrokeCon 2012 and president of ISA Stroke School. He's a founder of Pune Stroke Group, ex-president of Society of Neurosciences, Pune, and Maharashtra Academy of Neurology. He has been PI of many multinational stroke trials, and amongst them, two include his PERFORM, which is stroke, BrainsGate, BG12, cortical venous thrombosis, Interact 2. So that's about Dr. Ichaporia. We have two moderators, Dr. Sase, who is again neurologist, professor and head of neurology unit, GMC Miraj. He's an experienced neurologist with career spanning over 3 decades. He has done his internal medicine from Shivaji University and pursued DM in neurology from Dr. MGR Medical University, Tamil Nadu. He has served in the Department of Medicine at Wanless Hospital, Miraj, before specializing in neurology at CMC Hospital, Miraj. He was a senior neurologist at Wanless Hospital, Miraj, and thereafter went to appoint as a director of Wanless Hospital. In addition to his clinical role, he has contributed significantly to medical education. He was a lecturer at Government Medical College, Miraj, and has served as postgraduate teacher and examiner in medicine at MUHS Nashik. Our second moderator, Dr. Harpit Singh Maan, again a neurologist and a director, Department of Neurology at Fortis Hospital, Mohali. He has done his DM Neurology from King Edward Memorial Hospital, Mumbai, and Internal Medicine from GMC Patiala. He is a director, Department of Neurology, Fortis Hospital, Mohali, clinical practice of more than 20 years and had neurology of DNB program. He has specialized training in active and experienced clinical practice in various neurological disorders. He has worked closely with epilepsy surgery program at KEM Hospital, Mumbai, and he has publication of original articles at many national and international journals. Our first speaker would be Dr. Vinit Banga, who has done his DM Neurology and Fellowship in Interventional Radiology and Neurointervention. He's an adjunct professor neurology in ESIC Medical College, Faridabad, Haryana, India, and associate director neurology in head neurovascular intervention, Max Hospital, New Delhi. He's a senior consultant neurology and neurovascular intervention, senior consultant and head. So he has a several career experience in various hospitals like Medanta. He has also done a European Master in Stroke Medicine from Austria and fellowship in neurointervention from Pacific Medical College and Hospital, Udaipur. And he has done his DM Neurology from Institute of Human Behavior and Allied Science, New Delhi. He has got many awards, including Gold Medal in MD Medicine, Best Poster Award, and Young Stroke Professional Scholarship, and presented in national conferences and vast teaching experience. Our second speaker is Dr. Nilesh Palas Diokar. Again, a consultant neurologist at Ruby Hall Clinic, Vanwari, Pune, and Noble Hospital, Hadapsar, Pune. He's a visiting professor in neurology at BJ Medical College and Sassoon General Hospital, Pune. He has done his DNB.
Pratiksha, why don't you put up their thing instead of just saying? Why don't you put it on the slideshow so that we can get all the details properly?
Oh, so I am on the slideshow. Are you not
No,
able to
it was
see?
not being shown. Yeah.
Oh.
Yeah, now it's come.
One second. I'll just check once again. I guess I
Yeah,
sorry.
now it's there.
Now it's
Has
there.
Dr. Nilesh joined? Yeah, okay. Continue.
Yeah. So once again, please let me know. Can you see my screen again,
Yeah, we
Doctor?
can see your
Done.
screen.
Yeah.
Yes, done.
I'm sorry. I was wondering. I was in
No,
the.
you're going very fast, so we cannot get everything that you're saying. It's
Okay, I'll go
better if
little.
you project their profile on the screen.
Yeah, sure, sir. I'll go little slow. So again, Dr. Nilesh Palasdiokar, who is a GM neurologist. So he's a consultant neurologist at Ruby Hall Clinic at Vanwari, Pune, and Noble Hospital, Hadapsar, Pune. He's a visiting professor in neurology at BJ Medical College and Sassoon General Hospital, Pune. He's finished his DM neurology from Seth GSMC KM Hospital, Mumbai, and MD internal medicine from Sion. So he has various clinical experience, like senior registrar in neurology in KEM Hospital, consultant at Avanti Institute of Cardiology in Nagpur. He was a resident internal medicine at LT Hospital, Mumbai. He has a publication in various national and international journals and as well as chapters in various textbooks. So this was our second speaker. Our third speaker is Dr. Biswajit Paul. He has done his MBBS, MD, DM
Just
neurology, and
show his profile.
yeah, sir. I am showing his slide is not seen again.
No, it's not being seen.
Why is it happening?
Yes.
Can you see now?
Yes.
Yeah.
I'll keep this slide only. I'm not going for slideshow because it's not visible, I guess. Yeah. So coming back, he has done his fellowship in Neurointervention Institute of Neuroscience, Kolkata, DM Neurology in Guwahati Medical College, Guwahati, and MBBS and MD Internal Medicine from Silchar Medical College, Assam. He has various work experience. He has worked as a senior resident in Department of Neurology, GB Pant Hospital, New Delhi, consultant neurologist in Hayat Hospital, Guwahati, Assam, consultant neurologist in Institute of Neuroscience, Kolkata, consultant interventional neurologist in AMRI Hospital, Kolkata, and consultant interventional neurologist at Manipal Hospital, Kolkata. Again, he has publication in national and international journals, and he has presented at national conference. So that was about all our faculty today. And I would now like to hand it over to Dr. Ichaporia to please take it ahead.
Yeah, welcome everybody. And we've been doing this program for the last 1.5 years, and it's been a great success. And more than anything, with every program, we learn many new things, and I'm sure we'll learn things today also. Uh, so I think Dr. Sase, would you like to say something?
No, I think we'll go ahead with our presentation.
Yeah.
Yes,
So
sir.
let's go ahead with the first presentation. Who's going first?
Biswajit Paul.
Yeah. Can anyone please share my slide actually? This
Yeah, I think you'll have to do the screen sharing.
sharing. Okay, let me try.
So at the bottom, you can see share screen and an arrow.
Yeah. Then yeah, open setting. Okay, just let me see. Just share. Just new. Yeah, just can one give me just 1 minute time? Yeah, just 1 minute. First.
Hello. Hello, can we start?
I'm trying to.
Sir, if there is an issue, then you can send it to me. We can share it from our end.
Yeah. Whiteboard. Zoom doc. Yeah. Advance. Just.
So were you able to find share screen below? Just
Yes, I have
yeah.
found. Then
Just click on it and share your desktop or whatever is easier for
open
you.
system setting something came.
Yeah, sure.
Yeah.
Um, Kalpita, can you share it if you have Sir's case?
Can you? Uh,
So, if possible, can you please mail it to us? Then I'll share
yeah.
it from mine.
Yeah. I'm sending.
Can we go on to Dr. Nilesh's in the meantime?
Yeah.
Till Dr. Biswajit gets his thing right.
Sir, I will share my presentation.
Yeah. Yes, sir.
Are my slides visible?
Yes.
Sir.
Yes.
Put it on slideshow.
Yes, sir.
Yep.
So, good evening all, and thank you Emcure for allowing me to present in this today's session, and thank you Dr. Ichabure sir for this opportunity. So today I am going to present a case of a young female. So this one was a 35-year-old female. She was a pre-morbidly healthy, non-smoker, and a good obstetric history. And she was admitted to us with one episode of generalized tonic-clonic convulsion. So she was rushed into the casualty, and when she presented to the casualty, she was slightly irritable, and we found that she was right hemiparesis were there. She was loaded with the antiepileptic, and immediately she was shifted for the MRI. So the MRI which we did was this. So this is the diffusion weighted imaging. It showed that she has suffered from an acute posterior circulation stroke. She had got a left pontine and right cerebellar infarcts. So with this imaging, we went ahead with an MR angio, and the MR angio shows that there was a occlusion in the basilar artery. So this was a young female. She came to us within window period, and within 1.5 hours to 90 minutes, we thrombolized with her with tenectase, and then she was taken for an DSA. So this was what our intervention neurologist, Dr. Lomesh Biru did. So these are his images. So it shows that there was a mid-basilar mid segment occlusion was done when this vertebral artery shoot was done. And obviously we can see that this vessel hasn't opened after the Tenet test. So she was immediately taken for an thrombectomy. Dr. Lomesh decided to go for an aspiration thrombectomy, and the groin to puncture time was around 15 minutes. So we could, the door to needle time was something around 120 minutes, around 2 hours. So with this, a good restoration of the vertebrovascular circulation was achieved, and the patient was intubated and she was shifted to the ICU. Then next day, her ICU course was slightly stormy. She had a right pneumothorax, and for that she required an ICD. She remained to be drowsy. On day 4, there was some deterioration on the left side, the right side power. So we did a repeat MRI. However, the repeat MRI showed evolution of the same infarct. No new infarct was found. So gradually the ICD was removed. The physiotherapy was continued. In view of no other comorbidities, we did her cardiac evaluation, which was normal. Her APLA profile was normal. Her ANA blot was negative. And because there was some deterioration later with consent with Dr. Lomesh, she was put on a dual antiplatelet, which was Plavix 75, aspirin 75, and Xarelto 15 mg. They decided to move to Mumbai for neuro rehab. There she did a very good recovery. She recovered well. She became almost independent with some mild ataxia and right-sided loss of dexterity. She joined back work, and further work she wanted to pursue in Canada. So over a period of 1.5 to 2 years, her blood thinners were reduced, and then she was put on clopidogrel, that is Plavix 75, and rosuvastatin 20. And in around September this year, she was planning to move to Canada. But this December again, it struck again. She again presented to our casualty with sudden slurred speech, ataxia, and again right side weakness. We did an MRI. I don't have the films right now because she was admitted in at some other place, and it showed that there were some multiple brainstem infarcts, and there was again a basilar occlusion. Again, we followed the same. Bridging therapy was given. She was thrombolized with Tenet test, and we shifted her for DSA. Thankfully, this time the Tenet test worked, and the vessel was recanalized. So she was again put on a dual antiplatelet and LMWH, and this is the third month. She's gradually recovering, although the deficit is much more than it was earlier, but she's on path of recovery. So basically, we were wondering what caused the recurrent stroke. We did again a transesophageal echo that was normal. We did a 7 days ECG loop recording, which was normal. A CT aortogram was done to find out whether there is some embolic source over there, that was normal, and a thrombophilia workup was done, that was again normal. So depending on that, what we thought that basically she was on dual antiplatelet, she was doing well. The moment we stopped her aspirin, she developed a recurrent stroke. So we went ahead with this clopidogrel genotyping, where we found that she had a genotype of CYP2 C19 gene, where she was a poor metabolizer. So we thought that she was a clopidogrel resistance was there. And once we stopped that aspirin, the clopidogrel alone, it was not sufficient, and she landed up in another stroke. So this was a case of recurrent stroke with clopidogrel resistance. The reason for the stroke, frankly, we don't know, but the recurrent stroke probably we postulate was due to stopping of aspirin and keeping her on only clopidogrel. The data regarding clopidogrel resistance in India, there are different trials which could some trials could there almost 44% of people in India might be clopidogrel resistance. However, the current recommendation both from the Heart Association and the Stroke Association don't recommend to do the the genotype test regularly. And there are certain strategies where we can overcome this resistance by increasing the dose of clopidogrel, by using more receptor agents like pasoprolol, ticagrelor, or cagrilor, or maybe ticagrelor. So this was a case which I thought we should share. And nowadays we have got a lot of single antiplatelet agents with clopidogrel, but I feel we should probably do the resistance test before shifting them on single antiplatelet. Yeah. Thank you, sir.
Yes, Dr. Sase.
Right at the beginning, I was wondering why was the second stroke and what is the cause of recurrent stroke? Because you find that all the investigations related to the stroke were all normal. So maybe that treatment part was, that you could not continue with the clopidogrel, and by stopping aspirin, she precipitated a second stroke. But what are the basic cause, we really do not know. I think that needs to be a little highlighted more. Why
Yeah, true, sir, true.
Dr. Harpreet?
You are mute, sir.
You're mute.
Yeah. So one thing I would have done slightly for a longer period is probably an ELR for a longer period. If you do ELR for more than 3 weeks, probably 95% chances that we might pick up in case she's got any paroxysmal arrhythmias. The rest, I mean, the cause of stroke, recurrent stroke, we don't know. Commonly, this is the same protocol we follow. We give DAPTs for 3 weeks to 3 months, and then we go on to single antiplatelet. But in this case, we don't know really the cause of recurrent stroke. So what do you think, sir? I mean, do you commonly advise ELR for a longer period of time or just for 1 week?
No, one or two things which, Nilesh, are you there? Yeah.
Yes, sir.
The thing is, at the first go for a young woman of 35, we must investigate more widely. In fact, we should do a TE with bubble to look for PFO. And so, it's a case of cryptogenic stroke. Now, cryptogenic stroke, the more we investigate, the more reason we find. So, definitely, I would have done a TE more vigorously.
We did it in the next admission, sir.
Huh?
We did in the next admission, second admission.
Yeah, but in the first admission, see, because, and I don't see really the rationale of, giving Xarelto in the first admission. I mean, are we thinking of cardioembolic stroke? Or are we thinking of in cryptogenic stroke or ISUS, as it is called, they have been found not to be useful. And to give DAPT with Xarelto is a slightly high risk proposition.
Right.
And unless, there is documented AF, there is no role for Xarelto. So DAPT, yes. First of all, you have acted very fast and very diligently, and you have opened up the vessel, which is a great thing. I mean, that is the way to go. I think that you must be complimented on. I wish you had shown us the second, the second MRI to show whether, the infarcts have increased or not. And what was the extent of the damage. So that is, so the first part, I think you have done beautifully well. And this Xarelto, I have objection to. And for a young person, I think you have to investigate very deeply. You have to pull out all stops. You have to do long-term AF monitoring. You have to look at the aorta. You have to do a T to look at left atrial appendage. Many times it is there. There can be a clot there. You should do a bubble study for PFO. And if the PFO is there, you may have to close it if it's large. And for a young stroke, I think we need to push very hard for that.
My question is whether, is this clopidogrel resistance significant to cause this next stroke? Or if I had put her on just plain aspirin 150, that would have been a better idea.
Now, I don't know why we don't know the cause. Now, I don't know this clopidogrel resistance. I always am little, this thing, how good it is and how good that test is and whether really that is the cause. Second time also it occurred in the same vascular territory.
Yes,
So,
exactly,
you
sir.
know,
Now
that
we are
is,
actually,
so maybe you should look at more carefully at the subclavian and the origin of the vertebral arteries, because it has occurred in the same territory, you know. So cardioembolic stroke is less likely. Look at that vessel again.
yeah,
Maybe
so we
do
are
a
planning to do
DSA
a
or
DSA
a
again,
CT
sir, after 6
angio.
months.
Huh?
We are planning for a DSA after 6 months.
Yeah, I think, you know, we need to investigate that. And if there's a treatable cause there, we should pursue that. And, you know, in a young person, so definitely we would push very hard.
Right,
So
sir.
I think we should look at that. You know, I mean, clopidogrel resistance as the cause of the second stroke, I would put that a little lower down. I would look more carefully at the aorta, at the subclavian, at the vertebral artery. And it's also very important that, you know, you gave tenecteplase and the basilar artery also opened up. So that's also another important teaching point, that uh, even large vessel occlusions do open up with IV therapy. It's not that every time you have to, I mean, we would prefer to do intervention, no doubt about that. But to our great surprise, not surprise, to our great joy, it opens up with IV therapy. So we save a lot of resources. So therefore, I'm a big advocate of giving IV therapy prior to doing mechanical thrombectomy.
What I feel that this time the clot was just a platelet-rich thing, and second
Now,
thing they
whether it
came
is, see,
immediately.
these are all, you know, whether it's platelet rich or fibrin rich. Now, we don't know all that. Yeah.
I mean,
I mean,
I
we've
also
not
thought
analyzed the clot. We don't know whether it's platelet rich or fibrin rich. And whatever
this
it
time
is,
they came
there is fibrin.
immediately.
There is fibrin. So you have to give a fibrinolytic agent. Now, it may be platelet, maybe little more, but that doesn't mean that you don't give thrombolytic therapy. I mean, on the type of the clot, you don't decide. And how do you know the type of the clot on angiogram or on MR? You don't know. It's only if you extract the clot and analyze it, then you would say. Otherwise, how can you say? You can't say.
True, sir.
So I would investigate her a little more deeply and
Like
look at
what else
all these
we
things.
shall do in
Yes,
her case, sir?
moderators.
So what else will you suggest for her? I mean, investigation-wise.
What is what?
Like what else shall we do in her investigation-wise?
I think you do a DSA or a CT angio proper.
Yeah. So that probably, sir, we thought we'll do it after 6 months of the event, maybe in May.
No,
6 months later, we are planning to
6
do
months.
that,
Why? No, you can do it now also.
Okay.
You can. Why do you want to wait? Because, you know, she's at risk for third stroke also. So we must investigate her. Do her. You've done her ANA and all.
Yes, sir.
ANA
That
Apella.
everything there. ANA, HB electrophoresis,
Okay,
Apella
all that
profile.
you've done.
We
So
have,
I think look more closely at the vessels and push hard for T. T you've done, no? With
yes, sir.
bubble you've done.
Yes, sir.
Yeah. So yeah, moderators.
Probably, I don't know whether it's a good idea to repeat a vascular workup again after 6 to 8 weeks and to have a longer ELR.
Okay, sir. Yeah.
Yeah.
Thank you, sir.
So, you know, investigation for cryptogenic stroke.
Yeah.
You know, cryptogenic stroke is the more you investigate, the less number it becomes. So if you investigate more, you find less and less cryptogenic stroke. Otherwise, you say it's cryptogenic and just leave it, which I don't think is a good policy. So you must push hard. You must push hard, especially in a young woman like this. Any oral contraceptive pills or anything?
No, sir. Obstetric history was absolutely okay. No OC pills.
You know, they take it for birth control and for, you know, period control.
She was not on any hormonal therapy, sir.
Is she migrainous?
No, sir. So no smoking, no migraine,
No
no
migraine.
HRT.
Yeah, so just out of the blue, it has occurred. So then I'd look at the vessels. Any chance of dissection?
Yeah. So that was only thing in mind, considering the
Any
same
massage
size.
to the neck, or this. So we'll have to look at all these things. So at the first instance, when Dr. Biru did the thing, I think you should look at the vertebral arteries and this thing for
So
any
vertebral arteries look okay,
dissection.
sir.
Huh?
It is vertebral arteries are okay. It is seen in that
Yeah.
DSA.
Yeah, Dr. Sarsay?
Uh, is it a good policy to start the posterior circulation, especially the same vessel? Is it good to start them on oral anticoagulants on a long-term basis?
No.
Not recommended.
No, unless it is cardioembolic, there is no evidence that it's beneficial. That's why I had objection to, giving DAPT and Xarelto together, because you just increase the bleeding risk without giving benefit of stroke prevention.
That to Xarelto dose was 15 milligrams, so that was not a prophylactic dose. That was a
Actually,
therapeutic
what
dose.
happened? She worsened in the ICU. So Dr. Lomis thought whether was some emboli, artery to artery embolism has occurred. So in that way, we had put it at that time. But that was
No, but
just
Nilesh, at that time you should show us the scan to say that it is worsened. Worsening can be due to many factors. It can be metabolic. It can be so many factors in the ICU, hypoxia.
actually MRI didn't show any new
Was she
lesions.
obese, sleep apnea, anything
No,
like
sir.
that?
No, sir. She was a young, healthy,
Snorer.
fitness freak. No, sir.
These, was she in IT?
Yeah, she is an IT professional. But then she's very
These IT
conscious about
people
her
know,
fitness.
they don't sleep at night, and the lifestyle problems are there. So, lifestyle, it's not only giving antiplatelet, it's also lifestyle modification.
Right,
They
sir.
eat a lot of fast food, sleep pattern is not so good, a sedentary lifestyle, uh, they have PCOD. Or, I mean, I'm just talking in general. I don't know about this case. I haven't seen her. I don't know how she looks. But many of these young strokes, we are seeing many, many, many now, many young strokes, especially in this IT sector. And we feel that it's a lifestyle problem. And, they
Yes, sir.
don't
Thank you, sir.
modify their lifestyle even after a stroke, and they get into trouble. Passive smoking, uh, we see it all the time. Yeah. So in addition to medicines, I think lifestyle modification, sleep pattern, circadian rhythm, uh, all these things have to be looked at.
Thank you, sir. Thanks
So,
a lot for your inputs.
Yeah, very interesting. Huh? And I must congratulate you on the rapid action for mechanical thrombectomy.
Thanks a
So
lot, sir.
that was really very good. Hmm?
so there is a question from the audience here.
Yeah.
What was the need to put case 1 patient on low molecular weight heparin post thrombolytic?
Nilesh?
Here we had put, considering there was in between some deterioration, hence we had put the patient on LMWH. Otherwise, it is not required.
Actually, there is no evidence that LMWH is beneficial.
Yeah, there is no
The
evidence.
only role of LMWH is for deep vein thrombosis prevention. So for stroke prevention, no role, except if there is a floating thrombus in the vessel, or if there is a dissection. These two indications, dissection, not intracranial, extracranial dissection. Intracranial dissection is contraindicated. So extracranial dissection, if there is uh, anticoagulation versus antiplatelet, both are found to be equally good. So perhaps you can give it. And very often we have given it in, these floating thrombi, which are there mainly in the carotid circulation, but occasionally they can occur in the vertebral circulation. But really, Still now, it's troubling me. Why did she get a stroke at such a young age and twice? Still, that question is unanswered. And I think we need to, not leave any stone unturned for the diagnosis. You should push hard in the first instance. Yeah. Shall we go on to the second case, Dr. Biswajit?
Can anyone share my slide?
Yes, sir. Yes, sir. I'll be presenting it for you.
Yeah, please. So, yeah. Good afternoon. Thank you, Dr. Echaparia sir, Dr. Sej, Dr. Man, and Dr. Emcure for giving me the opportunity to present this interesting case. This patient is a young patient having a stroke, and I'll present that how we have managed this patient. Can you please say yes? This patient is 46 years male, medical graduate, chronic smoker. So on 9th January, he had acute onset of slurring of speech along with difficulty in finding words while on duty in the hospital and feeling slight heaviness on the left side of the head. And it was not associated with headache, vomiting, loss of consciousness, convulsion. There was no history of neck pain, no limb weakness, and no history of head or cervical injury, chest pain, palpitation, breathlessness, no history of fever, joint pain, rash, weight loss, oral or genital ulcer, or any kind of medication. So, as the patient in the hospital, we were present, and so we immediately took him to MRI room. And he is chronic smoker, I have already told, but there was no, as such, there is no risk, any kind of risk like hypertension, diabetes, cardiac disorder, no family history of hypertension, diabetes, stroke or cardiac disorder. Next. Yes. On examination, patient was conscious, but there is word finding difficulty, power. There's a right-sided limbs 4+/5, plantar right side extensor. This hemiplegia, hemiparesis with stable vital parameter and CVG is 97. Next slide. Yes, this is the MRI. As we took the patient to immediately to the MRI room. So in the MRI, there is a hyperacute infarct in the left MCA territory in the distal branch, and the MR angio. Next, yes, MR angio. There's no as such abnormality. So as the patient next. As the patient was in the within the window period, so immediately we took consent. Actually, we informed his family, and immediately we started IV thrombolysis with tenecteplase place as per the body weight. And after IV thrombolysis, within 1 hour, mental cloudiness promptly improved, and clarity of speech and mental function improves within 1 hour. This is the post IV day 1. There's a small infarct in the left temporal region, and patient initially was kept in the ITU for 1 day, and after that, and we shifted to ward, and we started investigating. So evaluating the his routine test was normal, and we did carotid Doppler, so check any plaque is there or not, because the MR was absolutely normal. We did 10 thoracic echo. There was no clot, vegetation, valve normal. Left ventricular ejection was 64%. And after 48 hours Holter, there was no AF. And then we did transesophageal echo. And the transesophageal echo, there was no clot, valvular disorder, or patent foramen ovale. And we also did it will ultrasound abdomen. There was no significant abnormality. So the patient was diagnosed severe stroke, that is acute left MC infarct. And after investigation, we came into this, probably it was ESAS. And follow-up discharge on the 4th day with single antiplatelet, that is ecosprin 150, atorvastatin, and vitamin supplement without any neurological deficit. And following discharge, we again did CT angiography of the brain and neck vessel. There was no plaque, stenosis there. And we did also did Holter, extensive Holter monitor, 7 days. There was nothing came. And on 8 months follow-up, patient was asymptomatic, was on a regular antiplatelet, single antiplate. Next, after 9 months, on 9th month, the patient on 21st September 2024, he had again another episode, that is the acute onset of right lower limb weakness noted at 3 a.m. on awaking from sleep. And last seen normal was 12 midnight. So again, he called in the emergency and came in our emergency. So it was a wake-up stroke, almost 5 hours. And on examination, there was right-sided pronator drift, and the power of the right lower limb was 4/5, others are normal. So it was a monoparesis, right lower limb monoparesis, plantar flexor, stable bitab parameter, all peripheral pulses was palpable. This is the second time stroke. So again, we did CT, then followed by MRI. MRI, there is a small infarct in the left SEA, the small infarct in the high parietal region. And also we did MR angio, it was normal. Then now, because as it is a second time stroke, we thoroughly investigated. Again, routine plus the other test also. ECG was normal, routine was normal, CRP was 1 milligram per liter, rheumatoid factor, serology negative, valve BDRL, ANCA, ANA profile, protein C normal, but protein S was slightly lower side. It is 57, and the factor 8 activity was high, 227. The normal range is 16 to 150. And serum homocysteine also slightly in the lower side. Next, yes. So as we did not get any strong evidence of the stroke, we did the DSA brain. DSA, there was a slight attenuation in the distal branches of the MCA and SEA territory. Next slide, please. Yes, these are the slight attenuation is there. In the medium and small vessel, there's a corkscrew type. So it is suggestive of vasculitis. Then we did lumbar puncture and CSF study after stopping the antiplatelet for 2 days. Protein was slightly high, it was 81, but the glucose cell count, other stain, gram stain, Indianing, fungal stain, BDRL, all other tests are normal. Next, yeah. During the hospital stay, his motor power of the right lower limb improved significantly and discharged on the 8th day without any neurological deficit with double antiplatelet and statin. Next, and on follow-up, patient was seen by the rheumatologist, and he started oral steroid along with the double antiplatelet and steroid, and smoking cessation was advised. And he was also advised for injection cyclophosphamide and the leptomeningeal biopsy, but the patient refused. And our plan is to repeat the DSA brain, but he refused this DSA. Then we just 2 days back, we did, next slide, please. We did MRI on the follow-up after 5 months of the next second stroke. There's a gliosis in the high parietal region. So this is new lesion, and this is away from that. That second lesion was in the left SEA territory, and this is in the high parietal. This is also in the SEA territory, but So final diagnosis is the recurrent ischemic stroke, probably due to medium and small vessel vasculitis associated with protein S deficiency with high factor 8 and also precipitated by smoking. So causes of stroke in young, as we know, that is either in the disease of the blood vessel, cardiac or hematological. Vascular, it is large, medium, small vessels. It may be inflammatory or non-inflammatory. And if it is inflammatory, it is primary CNS or it is systemic vasculitis. So like that, we have worked up this patient. Next slide, please. Yeah. So vasculitis, large vessel vasculitis, mainly atherosclerotic dissection, fibromuscular dysplasia. These are the large vessel vasculitis. And the small vessel, it may be divided into infectious and non-infectious. The non-infectious pain, Wegener's, lymphomatous granulomatosis, vasculitis associated collagen, SLE, geogran, like that. Next. Yeah. Cardioembolic, valvular arrhythmia, bacterial endocarditis, mitral valve, patent foramen nobile, myxoma, cardiac surgery and procedure. So in our cases, actually, that is the heart, there was no arrhythmia and the valves was normal. There was no patent foramen nobile. Hematological disorder also we have evaluated, but we found that is a protein S is slightly deficient with increased factor 8. So protein S is the anticoagulation. So deficiency causes thrombosis, and increased factor 8, it is procoagulation. So it enhances the coagulation. So in our patient, there was slightly deficiency protein S with increased factor 8. Next slide, please. Yeah. So primary CNS vasculitis, it is rare, frequently misdiagnosis. Large vessel, it is easily identified the cerebral angiography, but the medium and small vessel disease, it can be easily missed with the cerebral angiography and the definitive diagnosis by the biopsy, leptomeningeal biopsy. Next slide. Yeah. DSA, cerebral angiogram, is often used to diagnose large and medial vessel. However, the specificity is low. Absence of DSA finding cannot rule out vasculitis. So result must be interpreted in consideration with the patient's medical history as well as clinical laboratory finding and the result of magnetic resonance imaging and MR angiography. Repeat angiogram to clarify the diagnosis. One of the close differential diagnoses is the reversible cerebral vasoconstriction syndrome. So that's why repeat angiogram required if anything comes positive in the first angiogram. Next. Yeah. So definitive diagnosis is, I've already told, it is leptomeningeal biopsy. It shows the vasculitis. Target biopsy, based on the MR enhancements. So sometimes the lesion is patchy, so it can be easily missed in the biopsy. So European Stroke Organization recommended brain biopsy if the DSA is normal and clinical suspicion of primary vasculitis. Next. Yeah. Role of CSF to see the inflammatory changes, high protein or high cell or both. However, mild pleocytis is elevated protein or both can occur in ischemic stroke of other cause, and to rule out the other possible causes of vasculitis. Next. So high resolution MRI, it has role in large vessel vasculitis. It differentiates vasculitis from atherosclerotic plaque and RCVS. So in primary CNS vasculitis is segmental, concentric, and homogeneous enhancement. Vessel wall enhancement, homogeneous enhancement is there. Next. So stroke due to protein C deficiency, it may be familial, may be acquired. Familial due to mutation of gene, acquired due to liver disorder, nephrotic syndrome, chemotherapeutic drug infection, surgery, lack of vitamin, OCP, pregnancy. So in our case, actually, there was no such acquired cause. So it may be mutation, associated with mutation. Next. Yes, next slide, please. Yeah, high factor, it is procoagulant. So high is always associated with large vessel stroke, may high in normal individual or in inflammation. So it is very difficult whether it is responsible for stroke or not. Next slide, please. So treatment of CNS vasculitis, it is steroid immunosuppression like phosphomide, cyclophosphamide, azothioprine, mycophenolate. There is a role of aspirin. So along with that immunosuppression, aspirin to be given to prevent the thrombosis, and duration of treatment is minimum 2 years. Next, yes. So etiology of stroke in young is wide than the stroke in older individual. In evaluating primary CNS vasculitis, it is essential to attempt to reach the definitive diagnosis using tool like histopathological or arteriography study. And prognosis is usually better in primary CNS vasculitis in the medium or small vessel vasculitis. And there is a role of increased factor 8 and factor S and C deficiency can cause stroke. And any role of smoking, actually smoking usually causes atherosclerotic vascular disease, and in this case there's a DSA was normal, there was no involvement of the large vessel. So that stroke, there is smoking precipitated by increasing platelet dependent thrombogenic factors. Yes, thank you.
So finally, you think it is what? It is vasculitis or it is a procoagulant state?
So it is vasculitis because the DSA finding, there was the slight narrowing and bleeding-like appearance, and this is
but you know, vasculitis usually primary CNS vasculitis has headache.
Yes.
This fellow had no headache.
Oh, no headache. No headache.
No evidence of any inflammation.
No. Actually, primary CNS vasculitis inflammation. CRP.
No systemic inflammation.
We have
but headache is I think headache is a very important symptom.
So it is seen in the literature that is there is a headache is there in 50 to 60% cases.
And the infarct you showed was large vessel or medium vessel?
It is medium vessel, sir. This is the first case. There was a distal MCA left, that is parieto-temporal region, and in the second case there is a small infarct in the left SCA territory, distal high frontal region. So it is probably because there's some changes in the DSA. So that's why I'm.
Can you show that DSA again? Let us see it. Can you show it?
Yes. Can one please show this DSA?
Yeah, because you went very fast. We couldn't. Dr. Sasay, Dr.
Yes,
Harpreet.
I'll just share.
Any comments?
Just a moment.
Harpreet?
Yeah. Dr. Pal, I just want to ask you one thing. I mean, the patient was discharged on atorvastatin 20 milligrams.
Yes, yes, sir.
First stroke. So commonly we give a higher dose in stroke patients, right?
Actually, his previous slides, please. Yeah.
Yeah, just show that. Where are you seeing the?
Next slide, please. Next slide. Yeah, I have enlarged this photo. DSA. Yes. Yes. I have marked this. There's a slight attenuation is there in the distal vessels, mainly the medium vessels.
What are you seeing exactly? You're seeing these small lumps. Is it a loop or what is it?
Actually, somewhere there was a loop. This I'm just showing. These are the loops, but here there is some cork screw type appearance, and this is not the loop. This is not the loop. So this is also not loop. So that's why there's some attenuation. There is so cannot tell that is.
Yeah.
There was no classical beading type appearance.
No, so what are you supposed to see? You're supposed to see beading.
Bleeding.
You're
Yeah.
supposed to see
So classical finding is beading, but there is no beading. But there is, if it is beading, then it is classical finding. It is definitive. There is vasculitis, but here there is a slight attenuation is there. Attenuation. These are the attenuated like that.
yeah. Okay. Okay. Dr. Sase, Harpreet, anything more you want to say?
No, I just want to
Are you
ask.
convinced about this angio?
Not actually.
Yeah.
Dr. Sase?
Symptoms wise also, as was mentioned earlier, because he did not have seizures, no behavioral changes, no visual changes, which normally they complain of. So symptomatology wise also, it's an isolated stroke.
Yeah.
Not with any other symptoms which are usually associated with primary CNS
Yeah, that is true.
vasculitis.
Very
Yeah,
true. Yeah. So, it's presented like a stroke.
Yes.
So
MRI?
without anything else. So that's why we have little doubt about vasculitis diagnosis.
Okay, sir.
And the smoking is there,
Yeah.
and the vessel which was involved was, I think, a medium vessel in the left parietal region,
Yes, sir.
temporoparietal region.
Yeah.
Can you show that MR angio again? MR angio first time.
This is the second time stroke. There's a
Yeah,
small
no, first time. Yeah, before this.
Before. Yeah.
Yeah.
This is the first episode,
Yeah.
sir.
So it is in the left temporoparietal region, proper wedge-shaped infarct.
This is probably medial vessel.
Yeah, medium
Yeah,
vessel.
sir.
Yeah, just let's see the angio, MR angio.
Yeah.
No.
Next. Yes.
Okay. Okay. Okay, I think we can't push it any further. So is that thrombophilic profile a red herring, or it is really important?
Because
maybe you should repeat it after, in the acute phase, sometimes you get all these vague reports. So you should repeat it after, say, 3 to 4 months, after stopping DAPT for some time and getting it washed off, and then repeating it again, because then the treatment may change.
Yes, sir.
Yes,
sir. Because our plan is to again repeat this DSA if the changes, any positive changes is there, or it is normal.
Yeah, maybe you can do that. Of course, best is to do a small leptomeningeal biopsy.
Biopsy, actually.
If you are really suspecting, I have my doubts about vasculitis, basically. But if you are really suspecting it, I think, this DSA and all is very subjective, highly subjective.
Yes, sir.
So if you really want a proper diagnosis, and the patient wants a proper diagnosis, which is important because treatment is different, a small leptomeningeal biopsy would be worth it.
Because
I don't know how specific this DSA is. How specific or sensitive? You said it's about, what, 70%? Huh? What did you say?
Sir, DSA, it is positive in large vessel vasculitis.
Yeah.
It's sensitive. It is more sensitive. But
yeah,
small vessel and medium vessel, it is easily missed, actually. 30 to 40%.
So that is what I'm trying to say, that, we are not very sure that it is medium and small vessel. And if it is large vessel, then MRI, contrast MRI with vessel wall imaging would be a better idea.
Yes, sir.
Yeah. Okay. So shall we go to the next case?
Thank you, sir.
Sir, there is a question from the audience asking HB of the patient.
What of the patient?
HB.
Hemoglobin.
HB.
Hemoglobin is 14. It was normal.
Okay. There is another question from Dr. Girish, which says, what's the definition of young stroke? Patient age is 46. So I was wondering.
Actually, it varies from 40 to 50 till 50. Some studies, they include the patient as a stroke in young.
Another question from the same doctor, Dr. Girish. Why MRI was done instead of CT brain plane?
In first case, actually, MRI was easily available, and the patient is medico. So our protocol is CT, NGO. But as the MRI was available at that time, we immediately did this MRI. This patient. In the second time, patient came in the wake-up stroke. So we first, and the patient was on single antiplatelet. So we did first CT to rule out hemorrhage, and then we did MRI and MRI.
Another question, what is patient's BMI and lipid profile?
Patient is the normal weight around just I have sold it was 76. I think I have already mentioned it is in the slide, and BMI is a normal BMI. Just risk factor is the he is chronic smoker, chain smoker. This is the risk factor.
What about lifestyle, sedentary lifestyle? Sedentary lifestyle?
No, medical person.
Huh?
No, sir. He's a DNB student actually. And
He's a what?
DNB is
DNB student.
Yes.
He's 45 years old.
5 years old.
Yeah, actually he was in state that is medical college, and then now he is pursuing this DNB actually.
Okay.
DRNB, this is critical care.
No, medical student doesn't give you immunity from stroke, huh? Okay, let's go to the next case.
Thank you.
Thank you, Dr. Bishwajit. Dr. Vineet?
Hello, sir. Good evening, sir.
Yeah, good evening, Dr. Vineet. Yeah.
Yudhvir, are you there? Do you have my slides with you? And unfortunately, I've just got out of the cath lab. So I think I've mailed them the presentation to.
Just a moment, I'll present it from your end.
Do you have the presentation?
Is my screen visible?
Yes, put it on slideshow.
Yes, sir.
Start from the second slide. Second slide. Yeah, so I have 3 cases in which there was this difficulty in decision making. Depending upon time, we can choose one or the other. So this is regarding the 37.
We are already getting late. So you take one, take your best case.
So I'll just do this then.
Yeah.
So 37-year-old female teacher by occupation presenting with transient hemiparesis 1 year before this index event. And when she presented to us, there was this weak, sudden onset blurring of vision while she was teaching in the school. And at 10 a.m., she noted that she also had difficulty in speaking. while writing on the blackboard, and she reached around 1.5 hour later. And on the way, she recovered while she was coming to the hospital. Even her grip weakness was less, the speech was better. So her NIHSS at admission was 2, and this is 11:30 a.m. in the morning. Next slide. Subsequently, we made a diagnosis of, she came into OPD because she had low NIHSS. She did not go to emergency. She came to OPD, and we made a diagnosis of recurrent TIA with acute stroke, probably partial anterior circulation stroke with left MCA syndrome. So we were confused whether to go for a CT or MRI. But here, because it was a history of TIA and there was low NIHSS, we went ahead with MRI. But while undergoing the MRI, the patient's grip further improved. Her NIHSS came down to 1. And next slide. This was her MRI. So there were some embolic showers involving the left posterior temporal area as well as the high frontal area. Next slide. So now we were worried whether to do thrombolysis or not, because now the NIHSS is 1. So she had now weakness in hand grip. Her weakness, which was there, has improved partially. Her speech slurring has improved partially. But we were weighing whether to go in for thrombolysis or not, because there was this low NIHSS. But when we considered her on an individual basis, she is a teacher. Her hand is very important for her because she has to write on blackboard. She has to keep writing. So that is why we decided, because even if with a low NIHSS, it's a significant disability, then we decided for thrombolysis, and finally was next slide. So this is now 1 p.m. But this is not the ending, obviously. Next slide. Around 2 p.m. now, when there was 48 milligram of TPA was already went in, we got a call from ICU that the patient is behaving strange. When we examined, she was confused, aphasic, right hemiplegic, and NIHSS was 18. We thought, what are the plausible causes? It could be first is ICH, so we immediately switched off the infusion and shifted the patient for a CT scan. Next slide. Next slide, please. So I think we missed a slide. So CT was normal. So we decided now what to do, because CT is normal. The patient has suddenly, yeah. So CT scan revealed no bleeding. So now we were not sure what has happened. So we decided to continue infusion, but we were wondering what to do. So we decided, okay, we have not got an angiography or a vessel wall imaging done. So we should do, one is an angiography. The second was an urgent echo to look for some cardioembolic source, which probably has migrated in the IC or MC and led to this high NHSS. But the patient was very irritable. The hospital set up, this is not my hospital, this was some other hospital. So it was, the anesthetists were not very keen on giving her midas. So it took us some time to stabilize. So it is now 2 p.m. Next slide. So finally, at around 3:30 p.m., which is now 1.5 hours, it took us so much time to do an CT angiography. In CT angiography, we found that the ICA as well as MCA was occluded. There was tandem occlusion. There was close aspect of in the patient. Next slide. So here I came into picture. I was contacted, and because now she had high NHSS, large vessel occlusion, we advised mechanical thrombectomy. The patient was confused. She needed time. So we decided that we'll wait for the consent. And the patient wanted case summary. We handed it over to the relative. They consulted local hospitals. Luckily, some of these hospitals had people who were very well known to me. So they also gave positive intent. Next slide. And now finally at 7 p.m., even after these positive counseling, at 7 p.m., they agreed for intervention. Now, if you look back at time, she worsened at around 2 p.m. We did the angiography around 3:30 p.m. Now at 7 p.m. she is agreed for intervention. Again, she is in a window period, but before we wanted to shift her to the mechanical thrombectomy, we wanted to do an MR to check for penumbra, because the patient was also very particular that what are the risks, what are the benefits, and all of that. Next slide. When we did the MRI, we found this was the MRI picture, patchy infarct there, but a relatively high core if you look at it. So next slide. Now the question here was there was significant core and but there was penumbra as well. So we should do mechanical thrombectomy or not. Now the time window has come to 9 hours 30 minutes. But we thought she's a young patient. There is still some penumbra, so we should go for it. And we decided to go in for mechanical thrombectomy. Next slide. So this was the mechanical thrombectomy. The first pass was not successful, but we were able to open ICA. Next slide. In the next pass, we were able to open ICA. Next slide. So this was the clot, and the patient did well, and the patient did fine. She is still fine. She still she has joined her job back and still follows up. The cause of the stroke here we got to know was MTHFR homozygous mutation, because we could not find anything, and there was very strong family history of deep venous thrombosis in her sister. So I'll end my case here because, as Sir said, there is want of time. So I'll end my case here. This was the post-operative CT scan, which looked fine, and the patient also did fine. We can stop the slideshow. So through this case, there were multiple decision makings at multiple point of times. The first was low NIHSS and thrombolysis, considering the disability. The second was when she worsened during IV thrombolysis, what to do. The third was after she decided for mechanical thrombectomy very late in the course, should we have gone ahead without doing any further imaging, or we did the right by doing an MRI? So both ways, I think it is fine. So yes, we probably lost 5 minutes by doing an MRI, but anyways, we thought that the patient has anyways lost a lot of time by taking their time, and the patient was very particular about the side effects and how much of it is damaged and all of that. And so there were a lot of decision makings involved at multiple point of time. So this was my case, and thank you.
Thank you, Dr. Vinit. Dr. Harpreet, Dr. Sarsay.
I think the decision making was a little delayed. Otherwise, the patient has done well despite decision being taken late for the mechanical thrombectomy. I think it's a grace.
Yes, sir. They took almost 4 or 5 hours to decide for mechanical thrombectomy.
Yeah, that is the problem. Dr. Sarsay?
I think Dr. Harpreet was saying something. He's on mute.
Dr. Sarsay, mute. Sarsay.
Yeah. Can you hear me now?
Yeah.
Yeah. So that's what I said, that despite the decision being taken late, the end result was good. And I think that saved quite a big lesion from occurring into that patient. So counseling is also a very important part of it. And people do have so many questions. And unless they are answered, they are not ready for these procedures. And especially working in the periphery like us, where mechanical thrombectomy is too far a distant decision which the relatives gave us. But I think a job well done in this patient.
Thank you, sir.
Yes, Vinit, I think you've done very good job with all the hurdles in place. What I was thinking, she had a TIA type episode at 9
Yes.
a.m.
Yes.
So that is highly suggestive of a large vessel occlusion. And then she got an NIHSS of 1. At that first instance, I think you should have done a angiogram, CT angio or MR angio. That would have shown us whether it was a low NIHSS with LVO.
Yes. Yes,
And
I do agree to that, sir.
yeah.
And but
So,
I
in
think
all
yes,
cases, we must see the vessels.
yes,
It's not enough to just do a CT scan or a MRI, especially in a tertiary center like yours. In the
yes,
periphery, yes, I agree, it's difficult. Now, there is a big controversy whether low NIHSS should be treated with IV TPA or not TPA, IV therapy, or do MT. I think now we are coming around to the view that if it is an LVO, we should go in for MT straight away. I mean, it's controversial. If you see the guidelines, they say no, you wait for worsening. But to wait for worsening, I find very, very scary. Very, very, very scary. And many of them do worsen
Yes.
with low NIHSS, like your case, NIHSS of 40-50% will worsen in front of your eyes. So now the question is whether you should do MT as soon as they worsen, or you should do MT before they worsen. So the jury is out on that. At present, people say that you do it after they worsen, but I find that little difficult to digest, because you're sitting on a time bomb.
I agree, sir.
And I would have gone in for MT as soon as you did the second CT and CT angio. I wouldn't want to wait, because now we don't want to see that penumbra. Whether that, first of all, we don't know whether how good that penumbra is, even if we do um, this penumbra imaging, how accurate it is, how quickly you can do it, how quickly you can interpret it. It all takes time, and time is of the essence. So if she has worsened at 2 o'clock, and the CT scan shows no major infarct and LVO, go in straight. And don't allow the family to take second opinion, third opinion, fourth opinion. It just goes on and on and on and on. So you have to say that this is the standard treatment all over the world. It is accepted, and this is the best possible treatment for this young lady, and just go ahead. The more second and third opinions you take, you are going to waste time. That clot is going to become more organized, and the brain is going to die. So just use your good offices and your persuasive skills and push ahead and just do it.
Yes,
That is
yes,
why I'm a little aggressive in this. But
yes, sir.
I don't like to wait. I hate waiting. I get very tense waiting, because, you're damaging the brain. And recently, somebody showed a very beautiful slide that every 12 minutes, one pea size brain you are damaging, one pea size. And finally, if you wait
Yes,
for an hour or two, it is a bunch of peas. It is a bunch of peas. So you just want to save that one pea size, one green pea size, small batana you want to save. So the more the more time you wait and take second and third opinions, and the family is all confused, and money is involved, and oh my God, it's one big headache. But you have very good persuasive powers, Vineet. You push hard and just do it.
yes, sir.
Huh?
Most
That
of the
that
time I
is
end
my
up
view.
doing it.
That is my view. I don't know if you agree or not,
No,
but
sir, I do agree to that, sir.
yeah,
But
I know there are difficulties. I am facing this difficulty every day, and I'm breaking my head over it, because
yes,
so much money is involved. The uncertainty is there. We don't know. We can't
yes,
prognosticate whether person will improve or not. They may not improve,
yes,
but
yes,
this is the best chance you give the patient to improve. You're not giving the chance. So
Yes.
what you have to say is, this is the chance that you're taking. We don't know whether he will improve, she will die, she will get a big infarct, she will need decompressive craniectomy. We can't predict. Prediction in acute stroke is impossible. At least I found that it is impossible.
True, sir.
You can't predict. So you have to give the best possible chance to the patient, and the best possible chance is to do early MT. That's it.
I agree, sir.
For LVO, early MT, no issue.
I agree, sir. We should do.
Yeah. So use your immense persuasive powers and just do it. Sorry for being little aggressive on this, but
No, sir.
you have
We
to be,
have to be aggressive,
you
and
have to be.
yes,
Otherwise,
yes.
you just waste time and produce disability, and then do decompressive craniectomy. And I don't like to waste time on doing this perfusion scan and this scan and that scan and MRI. It takes another half an hour, 45 minutes, and you're just increasing the P's, you know. So
True, sir.
don't
True,
let the
sir. True.
speeds increase.
True, sir.
I think this P's, because when we tell the patient that so many neurons are dying in 1 minute and 10 minutes, they can't understand this. So you show them this Watana, this P, and with every 12 minutes, one P is getting added to the, and then in 1 hour, you'll have a bunch of P's. So do you want that? Or you just
True,
want
sir.
one small little
That's
P?
a very nice example to give.
Yeah, it's a good example. So that is how we need to pursue and be aggressive. Sometimes little rude also. We don't like to be rude, but sometimes you have to push hard.
True,
Then
sir.
some relative will come from somewhere, or some doctor, sorry, some GP will say, no, 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 we'll wait, let me come, let me talk to the family. Oh God, this thing just goes on, and we damage the patient.
True,
So
sir.
at least these are the difficulties I face. I don't know what you face,
No, sir. Like we
but
do
I'm
face the
sure you
same
face
thing.
the same thing.
Yes, yes.
Everywhere
Everywhere
in
is
the
the
world,
same.
people are facing the same thing. But
Same
you have
thing.
to say that it is level 1A, class 1A, level A evidence all over the world accepted. 1 in 4 patients will improve. Others we don't know. We cannot prognosticate. But this is the best chance that you give the patient.
True, sir.
Okay. Any more comments? Harpreet, do you agree with this philosophy or you don't agree?
Definitely agree, sir. This is the only way. This is the only way we have to.
Otherwise,
We have to be aggressive.
Sase?
I think push in hard,
Yes.
push
But
in hard and make
the
decisions.
pushing, you can only push if you are convinced.
That's true.
So, you have to have that conviction power, that you have to be convinced. Otherwise, you can't push. Your body language, your speech has to be confident. And that is the only way to push ahead. And this is a very common problem that Vinitas is facing. And we face it every day, or not every day, or very often we face it. And I find that this is the only way to go ahead. If we, and our rates of doing thrombectomy, because of various problems, availability, affordability, accessibility, are very low. So we have to push it. It's a good treatment. It's a very good treatment. So if IV hasn't worked, then definitely go in for it. There's no question. And young person, no, she was what, 35? What was she? 30?
Yes, sir. 35. 35.
Yeah. So no, whether she's a teacher or a housewife, everyone needs speech, yaar. ऐसा नहीं है कि only teacher needs, professor needs speech. अरे housewife also needs speech, yaar. Everyone needs speech. Who doesn't need speech? So so push ahead. Okay. Thank you, Pratiksha. Can you take it forward?
Yes, sir.
So just one last question from
Arre
Dr.
baapre, we are tired. Come on.
It's a small one. So why infusion of tenecteplase was given, not bolus?
Vinny?
No, so we gave the bolus. It was standard. We gave bolus followed by infusion.
No, you just confused the issue a little bit, Vinit, by saying infusion we stopped, and so I got confused. That means which drug did you give? Which infusion were you giving?
So it was we gave here the neurologist who was treating gave Actylise to the patient. So Actylise was given as a bolus and the infusion, and then when the 48 milligram of the total infusion dose was gone, then
Actylase
she
was
worsened.
given. So
Actylase.
so this is another important point. I couldn't get that point, but I was wondering why infusion are you saying, you know? But anyway, for LVO, the drug of choice now is tenecteplase. It
Tenecteplase.
is not
Yes.
alteplase.
That was one of the other reasons to present this, because
Yeah.
if we would
So
have
the
done the
drug of choice
angiography at the
now
onset, we would have
even
given Tenecteplase.
in the guidelines also it's clear that tenecteplase should be preferred. It's not the drug of choice. I wouldn't use that word. It is preferred over actylase for large vessel occlusion prior to
True.
mechanical thrombectomy. That is the exact
True,
word.
sir. True.
Hmm?
True, sir.
Okay. Okay, Pratiksha.
Yeah. So thank you everyone, especially the speakers, Dr. Biswajit Paul, Dr. Nilesh Palasdiokar, Dr. Vinit Manga, to bring this interesting cases into this forum and making very interesting discussion. Our moderators, Dr. Harpreet Singh Maan and Dr. Sase, who has given very valuable inputs to this discussion. And finally, yes, absolutely, Dr. Ichaporia, to take this through the entire discussion and making is this really interesting and educating. And I hope that everyone on this call have got valuable inputs and have learned some of the other things. So that's added to their knowledge benefit. So thank you everyone on the call. And
How many people attended?
yeah, sir. Just a second. So we had 485 live.
485.
Yeah.
So many people attended.
Yeah, that's the number I got. I was also a little shocked, but that's the number I
Yeah,
got.
that's a good number.
Yeah.
That's a good number. Okay. Thank you, everyone.
Thank you, sir.
Thank you. Good
Thank
night.
you.
Good night.
Good night. Good night.
Chalo. Thank you. भूख लगी